So good morning. I am so pleased to be with you this morning. My name is Patty Mouton. I serve as Vice President for Outreach and Advocacy for, for Alzheimer's Orange County. And I have a special guest with me this morning as well. Mona El Kurd is a licensed clinical social worker with a special fellowship from NYU in palliative care. She has been in hospice and end-of-life care for about 30 years, most of which here in Orange County. So many of you know her. She's the staff outpatient social worker for the Hoag Palliative Care program, and she provides counseling, advanced care planning, and helps to refer patients to all the appropriate, wonderful community resources we have here in Orange County. She also sees patients in the Radiation and Cancer Outpatient Treatment Center at Hoag, and she provides education to the Hoag staff and the community about end-of-life care and coping with serious illness. Please welcome Mona El Kurd Mansour. She's my guest today, and we're going to go through a few things talking about navigating POLST, especially during this crazy, crazy time of COVID-19. Many of you know that we prepare for everything. We have wedding checklists. We do baby shower and baby classes. We prepare for retirement. We get ready for just about everything with a checklist and a plan. And many of us don't let our feet hit the floor in the morning without a plan. What's really surprising is that even though we all believe we're going to age this vibrantly, that this is how we're going to spend our retirement, most of us do not. And we think, oh, well, illness and infirmity and frailty isn't going to happen to me. I'm healthy now. I don't know where to start to plan for a serious illness. I don't want to think about it. My family will know what to do, or my physician will tell me when it's time. Well, I'm here to tell you with my colleague Mona that that's really not the case. I'm going to talk a little bit about a recent family that you helped where the POLST and COVID kind of collided and they had to do things a little differently than they anticipated.
Yes, Patty, I will. So just in general, since COVID, my experience has been that my patients are more likely, more willing to fill out a POLST form. And before COVID, I was getting POLST forms completed by my patients. But since COVID started, I would say it's probably increased by 50%. And I think people are afraid, as you can imagine, with COVID. And when they think about, they're understanding a little bit better about what a ventilator is and what that means. I have a patient right now that was diagnosed with ovarian cancer about 3 years ago. Very, very smart woman, very highly educated, trained at Yale. And we met about 3 months after COVID hit Orange County, like probably around May or June. And we talked about her advanced directive, which she had completed. She did not have a POLST. She was not familiar with the POLST. So we spent part of our Zoom session going over the POLST. And under Section A, those of you that are familiar with the POLST form, she selected do not resuscitate. You know, she's very accepting of her illness, knows that it's terminal, isn't sure how much time she will have left to live, and does not want to have a ventilator. However, under Section B, where the options are full treatment with a trial period, selective treatment, or comfort care, she said that if it was not for COVID, she would have selected selective treatment. But because of COVID and the potential of getting COVID, she chose full treatment with a trial period. And her thinking behind that was, I don't ever see myself being on a ventilator with the terminal illness that I have, but what if I caught COVID? And what if I was in the emergency room? And what if my breathing became labored? And what if that was going to save my life? So we decided that as time goes on and as the pandemic things change and she's vaccinated, if she's in fact still alive and she feels her quality of life is as good as it is now, we will redo the POLST and she will change that to selective.
Thank you. So a lot of things are changing with COVID. And I think it's really important for us to keep top of mind that when people are in a healthcare crisis, especially now with this COVID pandemic, loved ones and advocates from family can't be with the patient in the hospital.
Absolutely.
So we want to avoid making decisions in a crisis. And very often, people who contract COVID get very sick precipitously. They're sick one day and then they're really sick the next day. And we do not want to be making important healthcare decisions during a crisis time. And I think what's really sobering for a lot of people is that 50% of us are not able to make a decision in a crisis. We're either too sick, we can't talk because we've already been intubated on a ventilator, we are unconscious, something has happened and we cannot speak for ourselves in a healthcare crisis. So it becomes even more important that when we are thinking about people that are frail, people that might be more susceptible to COVID and become ill more quickly, we need to be ready well ahead of the crisis. Choose a medical decision maker. I can't say this strongly enough. Even if you never fill out all your paperwork, at least talk to your family and friends and decide well ahead of the time you would need them, the person who would speak for you in the event you couldn't speak for yourself. Even better, to put it in writing in the form of an advanced healthcare directive. You have to trust this person. And this person has to be able to make really difficult decisions for you in a heartbeat, because that may be all the time they have to make a decision. You want to think about what would your last days or weeks of life look like? Where would you want to be? In the time of COVID, if you get into the hospital in the ICU, chances are if you get very sick and perhaps you're not going to recover, you're going to end up spending your last days in the ICU. So we want to counsel people so that they know what their options are and what their decisions mean. So Mona, have you had anyone say, well, what if I get really sick? I don't want to be in the ICU. How can I ensure that I get to stay home even if I get COVID?
Yes, that is a very good question. And Patty, I just want to go back to something you said earlier when you talked about choosing someone to speak on your behalf. Just yesterday in my office, one of my colleagues who was seeing some patients in the hospital, she came back to the office and we sit near each other and she said, Mona, I just spoke on the phone with the agent for a patient and started talking to him about the decision of whether or not the patient should be intubated and his code status. And what this man said to her, he was the roommate of our patient. And he said to her on the phone, what do I know? How am I supposed to make that decision? I'm just a roommate.
Exactly.
And you know, we kind of talked that through and how important it is to choose someone that you know knows you more than a superficial level, someone that knows your values, someone that knows what's important to you, and more importantly, or just as importantly, what that means as far as decision making, and talk about the specific things that are going to come up. And I think many times we choose people to be our agent without having that kind of deep discussion. And just like you said, we plan for baby showers and weddings and births, and we sit and we make lists and we probably talk those things, you know, just nonstop. But when it comes to these kinds of decisions, we maybe are a little bit more superficial because it's uncomfortable. It puts us in a space where we're not really comfortable, and we maybe sometimes we just talk about it on the surface. Exactly.
People don't want to contemplate their own death.
Yes.
And so what what our job as professionals has to be is to help people tell us, elicit what their ideas and their hopes are. What are their fears? What kind of care would they want? And where do they want to be if they're spending their last days?
Yes. And I know I haven't yet answered your question about COVID, but I want to kind of frame it in how we can arm ourselves with the ability to have these conversations. There are amazing things available to us to read, as simple as the 5 Wishes document. And not everyone may use that as a document. They may use, the California Advanced Care Directive form. They may get something through an attorney that's very similar. But the 5 Wishes document, if you were to look at it, it has my wishes for how comfortable I want to be, my wishes for how I want people to treat me. And then it's got, 8 or 9 points under each section. My wish for what I want my loved ones to know. I think we need a way to frame the discussions. And since it's not something we do think about, another really great book is called A Beginner's Guide to the End. And I am going to answer your question. It's written by B.J. Miller and Shoshana Berger. And we've had the chance to interact with them, you and I, Patty. They're amazing people. And when I met with them about a year or 2 ago, right when the book was coming out, they told me that how this book came to be is that they were invited to a think tank in San Francisco to talk about death and dying. And as they were sitting there with these very intellectual Northern California startup type people, one person said, well, when I die, I'd like to die on a glacier somewhere in Alaska. And another person said, well, I want to die listening to my playlist. Shoshana's father had just died of end stage Alzheimer's a few months before that. B.J. Miller is a palliative care physician. If you Google him, he's a TED Talk guy who's been talking about end of life for years. They got together after this think tank discussion and thought, you know what? All pregnant women buy a book called What to Expect When You're Expecting. Nobody buys a book about how to prepare for death and dying. And any human should read this book. You don't have to have a terminal illness. You don't have to be frail. You don't have to be elderly. You just have to be human and be 18 years or older and be able to, make decisions. So that's how this book came to be. So I'm going to go back to another patient that I have. This is pre-COVID, but it does in a way answer your question. She found me a year ago. She was at a conference at UCI Medical Center. And she was saying, I need to fill out a POLST and I need to fill out an advanced directive. I think mine's outdated. And someone at the conference said, well, there's people at Hoag that can help you. So long story short, she ended up she physically came to Hoag, went to a department, got sent to me and showed up at my office. And we made a meeting together. Obviously, this was before COVID. We sat down. I looked at her advanced directive, which was outdated, didn't have a choice. There was not a choice about whether or not to prolong her life. The verbiage on it was super confusing. It selected her son, but didn't have a choice. And she did not have a POLST. So I told her that the advanced directive she had was not clear. We completed another one, and she chose not to prolong life. By the way, she had Parkinson's disease and had it for 10 years. She was in her 70s. So we filled out the advanced directive. On the POLST, she selected do not resuscitate, comfort care, no artificial means of nutrition. She was very clear about what she wanted, but she had never really thought about the details, about where she wanted to be and what was important to her. So I recommended this book to her. We left our meeting. At the end of our meeting, she said to me, Mona, I feel like a burden has been lifted off my shoulders. And she began to cry. So I felt my job was done. You know, this is why we do the work that we do. I just felt really good. This woman's going to have an advance directive that's clear and complete. She's going to have a POLST. She's going to get the advance directive witnessed. She's going to get the POLST signed by her physician, and she's going to send them to me, and I'm going to get them in her medical records here, and my job is done. Well, about 3 weeks later, I get an email from her. She read the book that I just referenced, A Beginner's Guide to the End. She looked at the 5 wishes document as a way to frame. And this is the first time in my 30 years of practice I've ever seen this. She had an 8-page addendum attached to her advance directive, very, very specific about where she wants to be, the smells and scents that she wants to have in her room. So many specifics. I've never seen anything like that. Most people on their advance directive don't really write anything very specific. I ended up getting three revisions of this. She would like think about it and then change something. So after about a month and 3 revisions later, her addendums were completed, and I had to keep uploading a new advance directive, you know, into our medical records. But her ability to be able to do that, her situation is a little bit unusual. Most people, I don't want to say unusual, but not common. Most people don't do that. But for her, that was really important. And she didn't know how important it was to her till she read and thought and processed and talked. And she says, if I hadn't read the book, if I hadn't read that other document, I would not have thought of these things. If I hadn't talked to you. So back to your question. Now, during the times of COVID, these specific things that this particular patient had, unfortunately, are being limited. People can't have their loved ones around them.
Right.
They can't necessarily be where they want to be because of COVID. And that is the very sad, heartbreaking, one of the many heartbreaking things related to COVID, not being where you want to be at the end of your life, not having your family with you, and making decisions, Patty, and all of you that are watching, making decisions. Families are sometimes making decisions based on the limitations of the pandemic. And what I mean when I say that is Hoag, like all the hospitals nationwide, have very, very strict requirements about who can visit during the times of COVID and the pandemic. So in the beginning, visiting hours were very strict everywhere. Then when the numbers lessened, they kind of lightened up. And in the past month, the restrictions of visiting have gotten back to where they were before. And what I mean when I say that is you generally cannot visit a patient in most hospitals unless the patient is dying, and usually on a comfort care pathway. And that's when a family member can come in, and sometimes more than one family member. So what I have seen here at Hoag, and I know is being seen nationwide, which is a concern for the future, and I believe will affect grief and make grief complicated, is that family members are making decisions about visiting, about decision making. So in other words, well, if I put my loved one on comfort care and I decide not to intubate, or if I decide to extubate my loved one, and I decide to stop the antibiotics, then I'm going to be able to visit. And my concern, and all of the concern of providers like myself, is that what if after that patient dies, what if the family member is going to think, well, maybe I should have kept them intubated longer, or maybe I should have intubated and I should have intubated. Maybe my loved one would still be here with me. Maybe there was a chance they could have gotten better. That is a
very
concern.
complicated.
That is a big
concern.
Yes. Yeah.
And you mentioned something about complicated grief. We really don't know how we're all going to deal with the grief and the really totally unanticipated problems that COVID has presented. And I think it becomes even more important for people to talk about what they would really want in this pandemic time, and under different circumstances, they might make different decisions. And you bring up a really good point in that any of these documents can be revised, can be redone, decisions can be changed if necessary, but it's really important that the core wishes be put into an advanced healthcare directive and that we know whom you want to be making decisions. And they can be fluid as the situation demands and changes.
Yes.
You want to copy everybody. Fax, email, pictures on your phone, all of those are valid copies of what you have prepared in your advanced healthcare directive. Mona mentioned the POLST. Many of us know that the POLST document is really just for people who have a serious illness. And it's this bright, obnoxious pink so that everybody recognizes it. It should travel with the patient, and it gives very specific wishes about care. Mona mentioned the different sections. Well, if we decide we want to have CPR, cardiopulmonary resuscitation, if we are found in cardiac arrest, not breathing, no pulse, do you want an attempt made to bring you back? And people don't think about just how low the percentages are of success in bringing someone back or bringing someone back to their previous level of functionality when they have undergone cardiac arrest and then been revived with CPR. It's a pretty low percentage of people who actually have a good outcome, even if they get revived. So that's an important consideration. And what we have to think about is if we have underlying disease, if we are already frail, then sometimes a cardiac arrest is part of Mother Nature's transition. But if I were to have a cardiac arrest today because I accidentally put a paper clip into the Christmas light socket, I want CPR. I want every attempt made to bring me back. But if I were to fast forward 25 years, when I have congestive heart failure and maybe a stage 4 cancer and a little bit of dementia percolating, then perhaps I don't want the attempt made to revive me because I would have a very low opportunity to come back to my level of functionality. Let's do a comparison. So Mona, the Advanced Healthcare Directive is for everyone over 18. Need the POLST document.
Who needs the POLST document? Yes. So anyone that has a serious underlying condition or anyone that is elderly and frail with a lot of, we say comorbidities. So they may not have a serious underlying condition, but they may be diabetic. They may have high blood pressure. They may have multiple small things that affect their health in such a way that they would not be able to respond to CPR the way a more healthy person would. So yeah, anyone with a serious underlying condition, anyone with a serious chronic condition that creates a great degree of frailty, and usually by asking people questions about their level of functioning, what they can do for themselves, what's changed over the past year or 6 months in their functional status, how many times have they been to the hospital? Do they want to go back to the hospital? Those are the questions that we ask. What could you do before that you can't do now? And that helps me and helps the person that I'm talking to know if the POST is an appropriate document for them.
And the Advanced Healthcare Directive gives sort of general wishes and suggestions for care, while the POLST is very specific. Things like, yes, I want CPR. No, I do not. Yes, I want to be on a ventilator. No, I do not. Yes. So the differences are general suggestions for care and very specific orders for care that could happen today. And this, I think, is very important. Your Advanced Healthcare Directive The main job of this document is to name the person who would speak for you if you can't speak for yourself. But the POLST could be completed by your decision maker. So you really want to trust that person and ensure that they know what you would want. We talked a little bit about the success rates of CPR and the fact that many people, as Mona said, who have other diseases, are frail for other reasons, have comorbidities, they don't respond well to CPR. And even if we can get that heart beating once again, they may not ever return to their level of functionality prior to the cardiac arrest. There are orders called a DNR, and it could be an out-of-hospital DNR, or it could be in the hospital. It really is just about whether or not we call in the crash cart and we attempt to resuscitate people. It is not a do not treat order. And I think that's really important for people to understand, is that even if we choose not to be resuscitated, we are still going to get aggressive treatment to take care of our pain, our suffering, and our comfort is going to be very important. This is the crux of our discussion today, and that is many people who are older, who have other pre-existing conditions, are likely to become extremely sick should they contract the COVID-19 virus. And they may get so sick that they need to go on a ventilator, often with very little notice. So we want to know if that's what they want. Do they want to be on a life support machine? Do they want maybe to not be the first to be considered to be on life support? And maybe they don't want one at all. But if we're caring for older adults, if we have them in an assisted living residence, in a board and care, in a skilled nursing facility, it's our responsibility to know how they would respond to these questions. And I love this. This comes from Dr. Vincent Nguyen. Hope is not a plan. We have to be ready because this disease hits us sometimes very quickly. And we are all in this together. Healthcare workers, clinical providers, people who are caring for older adult loved ones, professional caregivers who have the responsibility for older adults in residential care or in skilled nursing facilities. We need to do this important work ourselves and have our own advanced directives. So let's talk a little bit about some of the patients that you have run into, Mona, where they really didn't think they needed to talk about their wishes for end of life, but all of a sudden they became very ill. So what happens when a patient now is faced with, oh my goodness, do I go to the hospital or do I stay home, even though I might not survive if I stay home?
Yeah, very good question. So it becomes tough. I mean, at that point, if they haven't had these discussions and they haven't put anything in writing, the hope is that if the patient is still alert and oriented, we can get these documents completed. But there are situations if that person does become ill where they're unable to complete the documents, and then the responsibility falls onto their loved ones. And that's when it becomes difficult, because if they're unable to make the decisions, they haven't filled the documents out and something sudden happens like COVID or something else, they don't have the decisions in writing. Hopefully a discussion has happened, but sometimes it has not, because part of the reason people don't want to put their choices in writing is they have to think about it and they have to talk about it. And people sometimes think if I think about it and talk about it, that means one, I'm giving up, or that means I'm surrendering to my illness, or that means something bad will happen. Once I talk about it, something bad will happen.
Right, we don't want to speak it into being. what I find really important, and at least it's encouraging that healthcare providers and hospitals are responding to the needs of patients with COVID, is that family members who are then put in a position to have to complete a POLST and determine what levels of care and interventions would be acceptable for that patient. A POLST can be completed with a telephone consent as long as it is appropriately documented by the healthcare provider, and the family can then have some input, but it's by telephone. Some hospice agencies and some providers are accepting a DocuSign electronic signature on a POLST and an advanced healthcare directive for this emergency situation. And so the POLST paradigm nationally is having to adapt to some of these needed changes. What we want to encourage everyone to do is to, number one, have an advanced healthcare directive. And I think Mona and I share the opinion that if you have people in your care who really don't know how to get started, we'll help them either by Zoom, in person if it's appropriate and possible, or we'll put them in touch with someone who can help them at least get the document completed, and then they can have conversations with their loved ones. So Mona, do you have any situations where you've had to like counsel people over the telephone and help them with these decisions during COVID in a remote kind of a situation?
Oh, every day, yes. So two different ways. So here we have our outpatient clinic, which is where I work. So all of our interaction, Dr. Nguyen and I, who are on the palliative care team here at Hoag, all of our interactions are by Zoom. So I meet a patient and family on Zoom. That my first initial contact with them, and these are patients that have a serious underlying illness, usually oncology, but not always. And the first thing I ask them in our first session is, do you have an advanced directive? Do you have a POLST? And they either answer yes or no to each of those questions, and then we start talking about it. And then we usually have a follow-up session. And as I mentioned earlier at the beginning of this talk, 50% before COVID, I was meeting people in person. Mm-hmm. Since COVID, I'm meeting people on Zoom, and I'm getting at least 50% more advanced directives and POLST completed over Zoom than I was in person in a clinic office because of COVID. I think this pandemic has, sorry.
No, well, you think that people are really sensitive to this issue and they're really understanding just how serious it could be if they do have to go to the hospital, go in the ICU, and that whole discussion about whether or not to go onto a ventilator.
Yeah. And when you were talking earlier about CPR, Patty, I think one of the things I tell people when they have an advanced directive or we're talking about an advanced directive, one of the first things I say to them is, if you choose not to prolong life in your advanced directive, in your advanced healthcare directive, that does not mean that you do not want to be resuscitated. I think a lot of people believe that if they choose not to prolong life in any kind of an advanced healthcare directive document, that means they don't want to be resuscitated. And that's when talking about the POLST and explaining that helps them understand that that means you do not want your life prolonged in your advanced directive at the end of your life. But if you choose that you do not want to have CPR because of your health, your age, your underlying condition, the likelihood that it will not be successful. And again, what does success mean? Success doesn't mean that you're going to, the CPR is going to be going to work and your heart's going to start beating again. Success means, are you going to get back to the previous level of functioning that you were before the CPR was performed or needed to be performed?
Yeah, I think COVID has really opened a lot of people's eyes. I spoke with a patient yesterday. She has 4 children at home, all teenagers, and everybody in the family had COVID, all at the same time. Mom, who is in her late 50s, was really feeling pretty sick. And she wanted to talk to me about whether or not she should go to the hospital and what would happen when she went to the hospital and what kinds of decisions she would have to make while she still could, because she was adamant she did not want to be on a ventilator unless there was no other choice. And so we talked a little bit about that. And I said, bring your husband in so he can hear what you have to say. Write down what your thoughts are, and you'll have at least a recipe card so that if you do become so sick you have to go to the emergency department, at least your family will have heard from you exactly what you would like your course of treatment to be. I think it's also important for those of us that are caring for older adults to understand that going on a ventilator does not necessarily mean the person is going to get well. One of the most recent statistics I read, and Mona, you can help validate this, is that about 88% of people over the age of 65 who become very ill with COVID and have to go on ventilators don't survive.
Yes.
So we really have a crisis situation here when people decide whether or not they want their last days to be either in an ICU or at home where they might be able to still interact with their families. What kinds of situations have you run into with patients in the ICU, Mona, where it's been particularly difficult for family members?
Yes. Many situations, Patty, but I would say the most difficult is when someone is in the hospital with COVID now, or even without COVID, but are in the ICU. And in either situation, they are intubated and they're not getting better. So they've got a ventilator, and attempts to wean them off this ventilator have been attempted, and they're not able to do so. The ICU doctors, the respiratory therapists are saying we're making attempts, but they need this ventilator to stay alive. So a family member who cannot visit and has not seen their loved one with this ventilator, except possibly on FaceTime, are having to make decisions to extubate their mother, their father, their sister, their brother, their daughter, their son, whoever it might be, without physically being with them, without looking at them face to face, without touching them, and having to make a decision over the phone with the physician, with one of our physicians, one of our palliative care doctors, with an ICU doctor, without being there with them. It is so heartbreaking. It is so heartbreaking. If the person had an advance directive and if they had a POLST, absolutely it would be somewhat easier. I think having the advance directive and the POLST minimizes the pain. It doesn't eliminate the pain. But if we can eliminate and minimize some of that unnecessary suffering because something wasn't in writing, having something in writing will eliminate that. That to me is what I call unnecessary suffering. The suffering is going to be difficult no matter what because you can't be there. But if there's something in writing, some of that suffering will be minimized. It's very, very tough. And people have said, how am I supposed to make that decision? I can't even see them.
Yeah. It's really wonderful that practitioners like you, Dr. Nguyen, other social workers and other palliative care professionals at all of the hospitals here in Orange County are so keyed in to minimizing the suffering of the people in their care, excuse me, and helping families who are faced with these difficult decisions. If you could give family members of an older adult loved one one message during COVID, what would that be?
My message would be this: do everything you can to keep the people that you love that are more compromised, to keep them safe, no matter how difficult it is not to see them and touch them and be around them. This is temporary. As we know, the vaccine by Pfizer has come out. Those of us here at Hoag are going to hopefully be getting that. Our staff, myself included, very soon. And the next step is everyone else is going to be getting the vaccine. So if we can just be patient and just try to be really patient with this, and know that your older loved one, the best way to show your love is to keep them safe and keep the distance, keep the mask on. I know the holidays are coming up and it's very, very hard. This is a blip in our lives. This time period of the pandemic is a blip in our lives, and it will pass if we can just get past it and keep everyone, but especially our older compromised family members safe, as much as our emotions may creep to the top and may get in the way. And I think the second thing is to not try our best not to shame or judge people that aren't functioning the way we are, with social distancing and hand washing and all the behaviors that go along with the pandemic. I think there's been a tendency to judge, and we don't know why people do what they do, or exactly what they're doing when we don't see them. So I think it's easy to judge, and I think it's sometimes a little difficult not to judge. And I think it's really important not to have judging or shaming, even within our own family. I've noticed a lot of family, and within one family, there's a disparity in how people are handling their behaviors with their parents. I've had a couple of people that say, I don't see my daughter because they're a non-mask family. They don't believe in masks. So for that reason, we don't see them. And that, that's hard for us, but that's just the way it is. And I'm trying, I one lady say, I'm trying not to judge, and that's their preference, but it's unfortunate we don't get to see each other barely at all, maybe from a huge difference, my front door at the end of the driveway, but nothing closer than that. So, but again, trying not to judge. It's a very personal decision.
Well, it is, except when we're thinking about the well-being of our entire community. And one thing that I want people to know is that if anybody needs masks, sometimes they're harder to get, or people don't want to spend the money. If you need a mask, contact us here at Alzheimer's Orange County, because we are distributing masks throughout the Orange County community. We have cloth masks, we have surgical masks, I have some KN95 masks, and we don't want anyone not to have one, or to have a couple of them on hand, so that they always have a clean mask, or they always have a new disposable mask ready for them to use, and never have that be a barrier to some of these safety precautions. That's just a blanket offer that if you let us know where you are, we'll find a way to get you masks. The vaccine starts to take hold, and as we start to see fewer and fewer cases coming into the emergency department and going into the ICU, what do you think families need to know about longer term support of their loved ones who maybe have had COVID and maybe are going to be a little bit more compromised? What do you think families should do? Let's say they got through the crisis and grandma got well and was able to come home. Now what with respect to their advance directive and their POLST form? How would you counsel families in that situation?
Very good question, Patty. I think it's important to revisit the advance directive and the POLST form, on a yearly basis, if people are able to, calendar that, because not only does our health change, our circumstances can change. We can behave one way and have certain wishes during a pandemic, and those wishes may be different when that pandemic is over.
Right.
Yeah,
Right.
very important. And then I also think too, if someone's gotten better, people may want to change their lifestyle a little bit. They may be less likely to shake hands with people. And I'm always wondering culturally what's going to happen with us after this pandemic, and how we hug and kiss strangers. We're a very touchy-feely society, and being touch is so important to our well-being, but I'm just
Mhm.
wondering, like, are we going to be as interactive with people that we don't know on in a touch manner that in the past we never really, a lot of people didn't really worry or think about? And I'm wondering if we're
Sure.
going to think twice about that that touching, feeling way that we interact. I wonder if that's going to change for people in general and people that are older and compromised medically.
I think everyone is going to go through a cultural shift. I think people are going to keep their hand sanitizer
Yes.
right at the ready, in their
Yeah.
cars, in their briefcase, at their desk. I think it is teaching us a really valuable lesson that this virus sort of descended upon us. And all of a sudden, we have to think about, how do we keep surfaces clean? How
Yes.
do we interact with people? And maybe we shouldn't be hugging and kissing and shaking hands all the time if that is the way these diseases get
Absolutely.
uh,
Absolutely.
passed back and forth. So we want to think about that. It's not enough to turn your head when you cough. You have to have some sort of a barrier.
Yes.
So I wonder now how we will be different. I think I will keep my hand sanitizer always at the ready. And I like it how people have developed some cute alternatives like the elbow bump or the fist bump or,
Yeah.
you know, the air hug from 6 feet away. I think that that is showing us we care about people, we're interested, but that we want to keep everybody safe. Because it's not so much what I might get from you, but it's what I might give you too. I could be unknowingly passing something back and forth. So I think we're going to have a little heightened awareness and a major cultural shift in how we interact with people. Um, the handshake may go away.
Yeah.
Pretty
Yeah, I've been
interesting.
thinking about that a lot and wondering what our lives are going to look like in that way, and culturally what shift is going to happen. It's going to be very interesting to see.
The cultural shift that I know you and I would like to see is that every person over the age of 18
Yes.
completes an advanced healthcare directive, because we don't know what the next pandemic might be, and we don't know what could happen to us. One of my favorite sayings is, I keep things prepared because I could get hit by a bus. Well, hopefully that will never happen to me, but I would want my family to know exactly what my wishes were. I don't want anyone to agonize and have anxiety over making decisions for me. And really, every person over the age of 18 should have someone named to be their healthcare agent. So this is an invitation to everyone listening that if you need an advanced healthcare directive form, contact Alzheimer's Orange County. We will get you one. We typically use the 5 wishes document. As Mona said, it's a wonderful, wonderful instrument for having a conversation with family members, and it kind of leads you through the conversation in a very comfortable, easy way. So let us know if you need an advanced healthcare directive. Let us know if you need help in preparing an advanced healthcare directive, or if you have a group of people, your Kiwanis Club, your church altar society group, any kind of a group of people, especially now that could meet on Zoom. We will have a conversation with them. We can do a formal presentation, or we can just have something conversational like we're doing here today, and help them understand how to complete an advanced healthcare directive, how to start the conversation with their loved ones, and then how to make sure that all the important people in their lives have a copy of this document, so that should something unthinkable happen, they're well prepared and everybody knows what steps they should take. So Mona, I know you're available to give talks in the community as well. You do
Yes.
mostly professional, but we can help put this together for people and make sure that if people want to get their advanced directives completed, that will help them in every way possible. So
Absolutely.
let's see, whether or not there are some questions from our audience. Do people have questions, or would they like us to elaborate on certain points? We have just a few minutes before our end time, and we're interested in what you have to say. So you can put something into the chat on Facebook Live. I think you can put something into the chat box if you're on Zoom with us. One of the most common questions I get is, do I have to have my spouse be my healthcare agent to make decisions for me? And Mona, what do you tell families when they ask, do I have to have my spouse be the agent?
Yeah, the answer is no. The person that you should choose should be the person that you feel understands your values and your wishes the best, and will be able to honor those wishes at a time of crisis. And in some cases, that might not be your spouse. And I've had one woman say to me over the years, it's been years since we've been talking about her filling out her advance directive, she firmly believes, I've known this patient for 5 years, that her husband will not be able to honor her wishes. So she has yet to fill out an advance directive because she's afraid of hurting his feelings, because she will be choosing one of her adult children. She's afraid to hurt him. And we've talked about how she can frame that with him so that he doesn't hopefully feel hurt. But it's not your spouse by default. It should be the person that will honor you, and that you knowing their character and how they cope under stress and what their value system is, someone that will as closely match your value system and be able to respect and understand your values.
Right. And sometimes that's not even a family member. I've had a number of people tell me that they have chosen a next door neighbor to whom they're very close, or a very good friend who has known them a long time and knows their family dynamics and could navigate those family dynamics well, while making decisions that are in alignment with what the patient has said they want. But I think this underscores why it's so important to talk about these things. Many families never talk about death and never talk about anything unpleasant. And I think while the thought of losing a loved one is terribly painful, certainly very unpleasant, death is part of life. And until we can accept that this is going to be part of our relationships with all the people that we love, we won't be able to come to grips with our own mortality, and it will be harder for us to complete these critically important documents. So, Mona, do you have a couple of closing thoughts of how we'd like to ensure people are well prepared?
Yes. So, I think the pandemic has in some way normalized these discussions, and they've normalized the use of the ventilator and what the ventilator looks like. I mean, the news was constantly talking about ventilators and the shortage of ventilators and, beds, hospital beds. So I think that has opened the door for people to think that could be me. That could be my loved one. And if there wasn't a time for us to start having these conversations, I don't know what time could be, what other time there could be. This is the time. This is the time. So many people have lost loved ones. So many people have died. And we don't ever want to put our families in a position where they have to second guess what it is that we want and what's important to us. And we want to minimize suffering at all costs. And the way to do that is to have your wishes in writing. It's that simple. There's some things we cannot control. We cannot choose where we're going to die. And we can't choose exactly every detail about how we're going to die, because there are some variables that we can't control. But there are lots of variables that are in our control, very important variables that are in control about life support and measures that can keep people alive longer than necessary. It's very, very important.
Nature intends. And I
Yes.
think we all share the opinion and the notion that life is precious and sacred, and none of us wants anyone's life to end any sooner than what Mother Nature intends. But we also don't want to increase suffering by prolonging a death event, using some of the measures and interventions that are available to us that are not likely to change the outcome. So that's a conversation that can be had beautifully with the clinical professionals should you or your loved one become terribly, terribly ill. But in the meantime, an advanced healthcare directive is essential. We're all talking about essential workers and essential services. An advanced healthcare directive is one of those essential documents that everyone over the age of 18 should have completed. Conversations about what you would find acceptable if you were seriously ill are also a critically important part of the process. And we want everyone to stay as healthy and as safe and as optimistic and hopeful as possible as we look toward getting this pandemic under control with vaccines. And we look toward our new normal, but we want you to be safe. We want you to live well. And we want to be able to minimize any kind of anxiety and suffering that's in our power. So with that, we're coming right up to our 11 o'clock hour. We promised we would end on time. We appreciate all of you joining us on this Facebook Live event. I want to thank Mona so much for being part of this and for sharing her wonderful expertise and really bedrock compassion for people that are in this very difficult phase of life when they're seriously ill. And we look forward to the next time we're all together. In the meantime, this is Patty Mouton from Alzheimer's Orange County and Hoag Palliative Care. Have a great day.
Thank you, Patty. Thanks, everyone.
Thank you.